Hello friends, hope you are doing well. So today's session is regarding an important topic, acute pancreatitis. Acute pancreatitis is very important condition. Hope you have subscribed this channel and press the icon, bell icon, right? So that you can get the new video I am uploading gradually. So acute pancreatitis is a inflammatory process of the pancreas with raised pancreatic enzyme level in the blood and urine. Another easy definition is inflammation of the pancreas secondary to leakage of the pancreatic enzyme from the acinar cell into the parenchyma of the organ. Overall mortality of the pancreatitis is about 5%. In first 2 weeks, mortality with acute pancreatitis is due to multi-organ failure. And after 2 weeks, mortality with the pancreatitis is due to inflammation, infection. Type of acute pancreatitis are two. First is necrotizing and second is non-necrotizing. Mortality is more in necrotizing type of pancreatitis. It is in necrotizing type, mortality is around 17%. In non-necrotizing, the mortality is about 3%. Best modality to detect acute pancreatitis is contrast enhanced CT scan. It is helpful in detecting especially necrosis of the pancreas in case of the acute pancreatitis. Now, what are the cause of pancreatitis? A very good mnemonic is I get smashed. So by this mnemonic, you can get the causes of acute pancreatitis. So I for idiopathic, G for gallstone, which is the one of the most common cause of acute pancreatitis. E for ethanol, which is the second most common cause. T for trauma, S for steroids, M for mumps, A for autoimmune, S for scorpion sting, H for hypertriglyceridemia and hypercalcemia, E for ERCP procedure, and D for drugs such as sodium valproate, azathioprine, and metformin. So these are the causes of acute pancreatitis. The pancreatic necrosis is considered significant when more than 30% of the gland is affected or area of the necrosis more than 3 cm is present. Echogenicity of pancreas in acute pancreatitis is normal in early stage and decrease usually so that pancreas become hypoechoic. Rarely, echogenicity may increase due to hemorrhage, necrosis, or fat saponification. Enlargement of the pancreatic body in acute pancreatitis, upper limit is 22 millimeter for the body. There is a term pseudopancreatitis in which in case of a fatty liver, pancreas may appear falsely hypoechoic. So we may think that the pancreatitis is present, but in reality, it is not. So this is pseudopancreatitis. Most common finding in acute pancreatitis on USG is peripancreatic inflammation, which is present about in 60% cases. Now, what are the USG finding in acute pancreatitis? So most common, I already mentioned, peripancreatic inflammation. Other findings are heterogeneous parenchyma, decreased gland echogenicity, indistinct ventral margin, it becomes irregular. Enlarged pancreatic gland, size of pancreas is increased. There may be presence of focal intrapancreatic echo changes. Other findings are peripancreatic fluid collection may appear around the pancreas. Focal masses may present. Perivascular inflammation may be there. Pancreatic duct dilatation may present. Venous thrombosis may occur. So this is a case of acute pancreatitis, and you can see this is the longitudinal section of the pancreas, and you can see there is coarse ecotexture is there. It is hypoechoic as compared to other local uh, structure surrounding it. There is increased AP dimension of the pancreatic body is there. So edema is there. Again, this is again a case of pancreatitis where diffuse enlargement of the pancreas occur and portal vein is having thrombus. This is again a case of pancreatitis where the heterogeneity of the pancreas is there and there is perivascular inflammation and there is splenic vein, superior mesenteric vein clot is also present. This is again a case of acute pancreatitis where there is inflammation is there and there is fluid collection is there superior to the pancreas. What are the imaging modality in acute pancreatitis? So role of ultrasound in acute pancreatitis is to detect gallstone as a cause of acute pancreatitis. It is also helpful to detect bile duct dilatation and obstruction. It diagnoses unsuspected AP or confirm the diagnosis of AP and also guide aspiration and drainage. What are the role of computed tomography in case of acute pancreatitis? It detects especially pancreatic necrosis, which is of utmost important. In case of severe pancreatitis, it detects the extent of necrosis, which having the prognosticating factor. It detects the complication of acute pancreatitis, diagnose unsuspected AP or confirm the diagnosis of AP, diagnose condition mimicking AP, including perforation, ruptured aortic aneurysm, and also guide aspiration and drainage. For prognosis, there is a criteria known as Ranson's criteria in case of acute pancreatitis. At admission, few factors are there we have to see, that is age, WBC count, glucose, LDH, and AST. And after 48 hours of admission, some other factors are seen like hematocrit fall, BUN rise, calcium, PO2, base deficit, and fluid sequestration. By this, we derive the score 0 to more than 7, and by which we can assess the mortality rate in case of the pancreatitis. You can remember mnemonic for the acute pancreatitis Ranson's criteria, gall, ito. So G for glucose, A for age, L for leukocytosis, L for LFT, that is AST, and LDH. This is for on admission. And ETOH is seen 48 hours after admission. E for electrolyte like calcium. T for third spacing or increase BUN. O for oxygen and H for hematocrit. What are the complications of acute pancreatitis? There are two types of pancreatitis complication. Systemic complication, which is related to the multi-organ failure. Local complication, for example, acute fluid collection, pseudocyst, pancreatic abscess, necrosis, infected necrosis, hemorrhage, and venous thrombosis. So these are the local complications which may arise in case of acute pancreatitis. Then different complications. Acute, first is acute fluid collection. The Atlanta classification suggests that differentiation between the acute fluid collection and pseudocyst should be made after 4 weeks from the onset of the disease. So before 4 weeks, we will say any fluid collection is known as acute fluid collection. And after 4 weeks, we will say it's a pseudocyst. Approximately 40% of the acute pancreatitis case develop acute fluid collection. Half of these appear to resolve spontaneously. Thus, drainage or other intervention in acute collection is inappropriate unless a rare superinfection occurs. Then pseudocyst of the pancreas. According to Atlanta classification, acute fluid collection is defined as acute fluid collection before 4 weeks, after the onset, and after 4 weeks, pseudocyst. Most common cystic lesions pancreas is the pseudocyst, which is present in about 75 to 90% cases. This pseudocyst occur both in acute and chronic pancreatitis, but more common in the chronic type of pancreatitis. The pseudocyst has given this name because unlike true cyst, they do not have epithelial lining, but their wall consists of fibrous and granulation tissue. This is a graphic representation of the pseudocyst occur in case of the acute pancreatitis. USG appearance of pseudocyst are, it may be purely cystic or it may have mural irregularity, septation, internal echogenicity because of necrosis, hemorrhage or infection. What are the indications of drainage of pseudocyst? Abdominal pain, biliary obstruction and GI obstruction. If these findings are present, then only the pseudocyst should be drained. Treatment option of the pseudocyst is usually conservative treatment is advised because many complicated pseudocysts resolve spontaneously. Second is surgery. Third is percutaneous image drainage, guided drainage. And fourth is endoscopic guided drainage. So these are the treatment options. Another complication is necrosis or abscess. There are two types of pancreatic related abscesses. Pancreatic abscess, which is due to an infected fluid collection or pseudocyst with minimal necrosis. And second is infected necrosis, with fluid collection arise from the infection of the necrotic pancreatic abscess. Treatment of infected necrosis is percutaneous drainage or PCD or surgical debridement. Treatment of pancreatic abscess is only percutaneous drainage or PCD. This is a pseudocyst causing the biliary obstruction. Longitudinal oblique sonogram of the two different patients demonstrate bile duct of dilatation from obstruction. Biliary obstruction is a indication of pseudocyst drainage. This is a pseudocyst after pancreatic fracture. The transverse sonogram show a fracture and laceration of the pancreatic body. Pseudocyst has been developed due to the pancreatic leakage. Trauma is uncommon cause of pancreatic pseudocyst. Now, vascular complication of the acute pancreatitis. Vascular complication can occur in both acute and chronic pancreatitis. Most important vascular complications are pseudoaneurysm and venous thrombosis. In case of pseudoaneurysm, clinically insignificant hemorrhagic pancreatitis due to venous or small vessel disease, potentially fatal hemorrhage occur due to enzymic digestion of the pseudoaneurysm of the major vessels, including splenic, gastroduodenal, and superior pancreatico-duodenal arteries. There is a term hemosuccus pancreaticus. Here, the vascular erosion can produce sudden painful expansion of the cyst or the gastrointestinal bleeding caused by bleeding into the pancreatic duct. This is known as hemosuccus pancreaticus. Then thrombosis of the portal venous system may occur both in acute and chronic pancreatitis. Splenic vein thrombosis is most common. Pancreatic vein thrombosis may also occur, but more common is the splenic vein thrombosis in case of the pancreatitis. Splenic vein thrombosis may result in upper GI bleeding from the gastric varices, and this condition is called sinistral or left-sided portal hypertension. The peculiarity of this type of portal hypertension is that the flow of the blood is hepatopetal or toward the liver, whereas in normal hepatic portal hypertension, the flow of the blood is away from the liver. So this is the difference in left-sided and hepatic portal hypertension. This is the case of splenic vein clot and thrombosis in case of the pancreatitis, acute pancreatitis. This is the pancreatic pseudoaneurysm formation is there. Doppler shows AP associated pseudopancreatism arising from the gastroduodenal artery. The clotted portion of the pseudoaneurysm is noted, which denote the absent portion of the patent portion of the pseudoaneurysm, and this is the clotted portion where flow is not there. Now we will review some MCQ regarding the acute pancreatitis topic. What is the lab finding which elevate first in the acute pancreatitis? So out of amylase, ALP, AST, ALT, ALP and lipase, amylase is the answer which is first elevate in the acute pancreatitis. When serum amylase rises in acute pancreatitis, so answer is 24 hours. Within 24 hours, serum amylase rises in acute pancreatitis. Next question is when serum lipase rises in the acute pancreatitis. So answer is 72 hours serum lipase elevated in acute pancreatitis. Which of the following would be the least likely cause of the acute pancreatitis? So out of these, that is alcohol, hepatitis, trauma and gallstone. Hepatitis is the least likely cause of the acute pancreatitis. What is the overall mortality in acute pancreatitis? So answer is 5% is the overall mortality. Most common cause of acute pancreatitis. So as we already discussed, gallstone is the most common cause of acute pancreatitis. Most common echogenicity of an acute inflamed pancreas is anechoic, hypoechoic, hyperechoic or calcified. So answer is hypoechoic. Hypoechoic is the most common echogenicity. What is the most common ultrasound finding of the acute pancreatitis? So answer is peripancreatic edema is the, or peripancreatic inflammation is the most common ultrasound finding, about 60 to 65% cases. Which of the following is the peripancreatic fluid collection that result from inflammation of the pancreas? So answer is phlegmon is the peripancreatic fluid collection that result from the inflammation of the pancreas. What is the normal value of the serum amylase? So answer is 25 to 125 unit per liter is the normal value of the serum amylase. What is the normal value of the serum lipase? So answer is 10 to 140 unit per liter is the normal value of the serum lipase level. True about the elevation of the serum lipase in acute pancreatitis, that increase after 24 hours and remain elevated up to 10 days, and increase after 72 hours and remain elevated up to the 14 days. So B is the answer. It increase after 72 hours and remain elevated up to 2 weeks or 14 days. Local complication of the acute pancreatitis are all except option are acute fluid collection, pseudocyst, pancreatic abscess, necrosis, venous thrombosis, or ductal calcification. So answer, ductal calcification is not present in case of the acute pancreatitis. Other complications arise in the acute pancreatitis. Acute pancreatitis is commonly diffuse, fluid, focal, or both or none. So answer is diffuse. Acute pancreatitis is usually diffuse one. Normal echogenicity of pancreas is same as that of the liver, lower than liver, higher than liver, or same or higher than the liver. So answer is same or higher than the liver. That is, it is isoechoic or hyperechoic as compared to liver. What is which the sentence is type of pancreatitis associated according to revised Atlanta classification: interstitial edematous pancreatitis, necrotizing pancreatitis. True or false? Yes, it is true. So two types are there: interstitial edematous pancreatitis and necrotizing pancreatitis. Diagnostic criteria for the acute pancreatitis is lipase amylase level elevation more than 3 times the upper limit of normal. This sentence is true or false? Yes, it is true. It should be more than 3 times the upper limit of normal. In amylase, in acute pancreatitis, Cullen sign, that is periumbilical bruising, Gray Turner sign, that is flanks bruising. This sentence true or false? Yes, it is true. Vascular complications of acute pancreatitis are all except hemorrhage, pseudoaneurysm, splenic vein thrombosis, thrombosis of SMV, portal vein thrombosis. So answer is thrombosis of SMV is not present. All other are vascular complication of the acute pancreatitis. Then diagnostic criteria for acute pancreatitis is enlarged edematous pancreas with pancreatic body exceeding 2.4 centimeter, 1.8, 2.8 or 3 centimeter. So answer is 2.4. It is 2.2 to 2.4 centimeter in diameter is the upper limit for the diagnosing acute pancreatitis. So that is all for today's session. Hope you have find this video valuable and useful. Don't forget to subscribe this channel, and to get more video, press the bell icon so that you can get the notification for the further videos. Thank you all. Thank you.